Acoustic Neuroma. Introduction. It's a benign schwannoma of the 8th cranial nerve, which is the vestibulocochlear nerve. It's also known as vestibular schwannoma, neurolomona, or an 8th nerve tumor. Acoustic neuroma is the most common cerebellopontine angle tumor, which is about 80%, and constitutes 10% of all brain tumors. This benign, encapsulated 8th nerve tumor is extremely slow-growing and consists of elongated spindle cells with rod-shaped nuclei lying in rows or palisades. Unilateral tumors are more common. Median age 52 years. In comparison, they are rare in children, except for patients with neurofibromatosis type 2. Bilateral acoustic neuromas are strongly associated with neurofibromatosis type 2. Pathology. It's a circumscribed, encapsulated benign tumor. Malignant transformation is very rare. The shape and appearance differ according to the consistency and the size of the tumor. Small tumors are usually pink or yellow and rubbery in consistency, whereas large tumors are more yellow, mottled, and cystic in consistency. Histopathologically, it's composed of Antoni A fibers, which are compact and cellular, and Antoni B fibers, which are loosely packed and cellular. Origin and growth of tumor. The tumor almost always arises from the Schwann cells of the superior vestibular nerve, but rarely from the cochlear division of cranial nerve 8 within the internal auditory canal. It arises from the Schwann glial junction near the Scarpa's ganglion and the internal auditory meatus. This zone is termed the Obersteiner-Redlich zone. There's an abundance of Schwann cells in this region, and hence its origin from this area is more common. As it expands, it causes widening and erosion of the canal, and then appears in the cerebellopontine angle. Here, it may grow anterosuperiorly to involve the 5th nerve, or inferiorly to involve the 9th, 10th, and 11th cranial nerves. In later stages, it causes displacement of brainstem, pressure on cerebellum, and raised intracranial tension, which may further lead to death if untreated. The growth of the tumor is extremely slow, and the history may extend over several years. It's necessary to know the growth pattern of the tumor because it determines the chronology of symptoms. The growth patterns are slow growth, 0.02 centimeter per year, medium growth, 0.20 centimeter per year, fast growth, 1 centimeter per year. Classification. Depending on the size, the tumor is classified as 1. Intracanalicular, when it's confined to the internal auditory canal. 2. Small size, up to 1.5 centimeters. 3. Medium size, 1.5 to 4 centimeters. 4. Large size, over 4 centimeters. Clinico-pathological classification. Stage 1. It is the otological stage. It includes all intramedial lesions, extramedial tumors up to 2 centimeters. It causes unilateral hearing loss with tinnitus. Erosion of walls of the internal auditory meatus is seen. Stage 2. This is a stage of trigeminal nerve involvement. After the tumor expands to the cerebellopontine angle in the medial direction, there is the involvement of the trigeminal nerve. Tumors more than 2 centimeters causes compression of the trigeminal nerve, leading to a decrease in corneal reflex. Stage 3. In this stage, brainstem and cerebellar compression are seen. Ataxia, direction-changing nystagmus, Brunn's nystagmus, and involvement of lower cranial nerves, 9th, 10th, and 11th. Stage 4. Increased intracranial pressure is seen in this stage. Papilledema, headache, and vomiting are the presenting features. Stage 5. This is the terminal stage. Failure of vital centers in the brainstem causes coma and death. Clinical features. Hearing loss. Hearing loss is gradual, unilateral sensory neural type, or asymptomatic sensory neural hearing loss, which is associated with impairment of speech discrimination, out of proportion to the pure tone loss, may be seen around 67% of cases. Atypically, there may be sudden hearing loss in 26% of cases and normal hearing in 1 to 5% of cases. Tinnitus. Seen in about 18% of the patients. It is high-pitched and continuous on the affected side. It coincides with hearing loss for which the patient may not bother about the symptom. Unilateral tinnitus, even if not accompanied by hearing loss, should be investigated for acoustic neuroma. Vertigo. May be seen in 18%. It is abrupt in onset, occurs early, and may last for days or weeks. It resolves spontaneously. It generally increases with head movement and exertion. Vertigo is seen more commonly and frequently in smaller tumors. Cerebellar dysfunction. Seen in around 48% of the patients. Ataxia or disequilibrium, which is continuous and unremitting, with the tendency to fall towards the side of the tumor, is the presenting feature. Trigeminal nerve dysfunction. It's presented as numbness in the teeth and hyposthesia of the midfacial region, atypically trigeminal neuralgia. Headache. This occurs in the early and late part of the disease. Headache is seen in the front occipital region of the ipsilateral side, worse in the morning or precipitated by head movement and exertion. Facial nerve palsy. Occurs late and in large tumors. Symptoms according to the involvement of region. Cochleovestibular symptoms. These are the earliest symptoms when tumor is still in the intracanalicular area and are caused by pressure on cochlear or vestibular nerve fibers or on the internal auditory artery. Progressive unilateral sensory neural hearing loss, often accompanied by tinnitus, is the presenting symptom in a majority of cases. There is marked difficulty in understanding speech, at a proportion to the pure tone hearing loss. This is the characteristic feature of acoustic neuroma. Some patients may get sudden hearing loss. Vestibular symptoms seen are imbalance or unsteadiness. True vertigo is rarely seen. Cranial nerve involvement. Fifth nerve. Trigeminal nerve is the earliest nerve to be involved. There is reduced corneal sensitivity, numbness, or paresthesia of the face. Involvement of this nerve indicates that the tumor is roughly 2.5 centimeters in diameter and occupies a cerebellopontine angle. Seventh nerve. In the facial nerve, sensory fibers are affected early. There is hypoesthesia of the posterior medial wall, showing Hitzelberger sign, loss of taste when tested by electrogustometry, and reduced lacrimation of the Schirmer test. Motor fibers are more resistant and are affected late. Delayed blink reflex may be an early manifestation. Ninth and 10th nerves. When glossopharyngeal and vagus nerves are involved, there is dysphagia and hoarseness due to palatal, pharyngeal, and laryngeal paralysis. Other cranial nerves. 11th and 12th, 3rd, 4th, and 6th are affected when the tumor size is very large. Brainstem involvement. There is ataxia, weakness, and numbness of the arms and legs, with exaggerated tendon reflexes when the brainstem is involved. They are seen when long motor and sensory tracts are involved. Cerebellar involvement. Pressure symptoms on the cerebellum are seen in large tumors. This is revealed by finger-nose test, knee-heel test, dysdiadokinesia, ataxic gait, and inability to walk along a straight line with the tendency to fall to the affected side. Raised intracranial tension. This is also a late feature. There is headache, nausea, vomiting, diplopia due to sixth nerve involvement, and papilloedema with a blurring of vision. On examination. 1. Otoscopy. There is loss of touch sensation in the posterior superior medial wall in some cases, known as House and Hitzelberger sign. 2. Nystagmus is horizontal and rotary type. 3. There is a loss of corneal reflex. When a wisp of cotton is placed on the cornea, there is no response seen. 4. Romberg sign is positive. That is, there's a tendency to fall to the affected side. 5. Pass pointing is positive in very big tumors. Tuning fork test. Rene's positive. Weber is lateralized to the healthy side. Absolute bone conduction is decreased. Investigations and diagnosis. Attempts should be made to diagnose the tumor in its autological phase when it's still intracanalicular. This is possible when all cases of unilateral sensory neural hearing loss with tinnitus or imbalance are carefully evaluated. Audiological test. Audiometry. Audiometry is the best initial screening laboratory test for the diagnosis of vestibular schwannoma, since only 5% of patients will have a normal test. Pure tone and speech audiometry should be performed in an acoustically shielded area. Pure tone audiometry will show sensory neural hearing loss, more marked in high frequencies. Speech audiometry shows poor speech discrimination, and this is disproportionate to pure tone hearing loss. Rollover phenomenon is seen, that is, reduction of discrimination score when loudness is increased beyond a particular limit. Recruitment phenomenon is absent. Short increment sensitivity index test will show a score of 0 to 20% in 70 to 90% of cases. Threshold tone decay test shows a retrocochlear type of lesion. On impedance, the stapedial reflex is absent. Brainstem evoked response audiometry. This shows a delay of more than 0.2 meters per second in wave 5. Comparison of wave 5 between two ears is significant. Wave 5 may be absent or prolonged in some cases. Electrocochleography. Broadening of the action potential and summating potential waveforms are seen. Large cochlear microphony. Presence of action potential at stimulus intensity less than the threshold and inaudible to the patient. Electronystagmography. Direction-changing nystagmus is seen when the cerebellar connections are involved. This is called Brunn's nystagmus. Vestibular test. Caloric test shows diminished or absent response in 96% of patients. When the tumor is very small, the caloric test may be normal. Neurological test. Complete examination of cranial nerves, cerebellar functions, and brainstem signs of pyramidal and sensory tracts should be done. Fundus is examined for blurring of disc margins or papilloedema. Radiological test. Plain X-rays. These are done in transorbital, stenverse, Townes, and submental vertical views. They give positive findings in 80% of patients. However, small intracanalicular tumors are not detected through X-ray. Computed tomography scan. A tumor that projects even 0.5 centimeters into the posterior fossa can be detected by a computed tomography scan. If combined with intrathecal air, even the intramental tumor can be detected. Computed tomography scan has replaced earlier methods of pneumoencephalography and myodelmatography. MRI with gadolinium contrast. It's superior to a computed tomography scan and is the gold standard for the diagnosis of acoustic neuroma. Intracanalicular tumors, or even a few millimeters, can be easily diagnosed by this method. Vertebral angiography. This is helpful to differentiate acoustic neuroma from other tumors of cerebellopontine angle when doubt exists. Differential diagnoses. Acoustic neuroma is the most common cerebellopontine angle tumor. It should be differentiated from other cerebellopontine angle tumors that are listed in order of descending frequency: meningioma, lipomas, epidermoid, cholesterol granulomas, cholesteatoma, arachnoidal cyst, aneurysm, metastasis, schwannoma of other cranial nerves, such as cranial nerve 5th, 7th, 9th, and 11th. It should be differentiated from cochlear pathology like Meniere's disease. The differential diagnoses for dizziness must be ruled out, which has a similar presentation to acoustic neuroma. They are Meniere's disease, vestibular neuritis, benign paroxysmal positional vertigo. Treatment. The treatment of choice is surgical removal. The second choice is gamma knife surgery. Conventional external radiotherapy does not have a role, as there is low tolerance of the central nervous system to radiation, and chemotherapy is also not given in the treatment regimen. Surgery. The surgical approach depends on the size and extent of the tumor. There are 3 standard operative approaches. The selection of a particular approach is determined by a number of factors, including the size of the tumor and whether or not the preservation of hearing is a consideration. Retromastoid suboccipital, retrosigmoid. The suboccipital approach can be used for any size tumor with or without attempted hearing preservation. Translabyrinthine. The translabyrinthine approach has been recommended for acoustic tumors larger than 3 centimeters and for smaller tumors when hearing preservation is not an issue. Middle fossa. The middle fossa approach is suitable for small, less than 1.5 centimeter tumors when hearing preservation is a goal. Gamma knife surgery. This stereotactic gamma irradiation therapy, or linear accelerator, delivers high dose of ionizing radiation to the tumor and minimizes its effect on the surrounding neural tissue. It facilitates the arrest of tumor growth and reduces its size. It can be used in the following patients: if the patient is not willing for surgery, when the tumor is less than 3 centimeters. Contraindications to surgery are the presence of residual tumors after surgery. Conservative approach. Patients who are elderly or have serious medical problems may be kept under wait and watch policy, as acoustic neuromas are slow growing. Surgical approaches for cerebellopontine angle tumors. Translabyrinthine approach. Indication: when the tumor is less than 3 centimeters size. Small tumor without serviceable hearing. Advantages: direct approach to the entire internal auditory canal and its contents. Highest rate of preservation of facial nerve. Immediate facial nerve repair possible. Minimal cerebellar retraction. Low recurrence rate. Neurologists are well familiar with the surgical anatomy of the area. Disadvantages: complete hearing loss. Sigmoid sinus, facial nerve, and middle fossa dura limit the exposure. Cerebrospinal fluid leak may be seen. Retrolabyrinthine approach. Indication: small cerebellopontine angle tumor not extending into the lateral part of the internal auditory canal. Advantages: neurologist well familiar with surgical anatomy of the area. Disadvantages: no access to the lateral part of internal auditory canal. Otic capsule, sigmoid sinus, middle fossa dura, and cerebrum limit the exposure. Middle cranial fossa or transtemporal supralabyrinthine approach. Indications: small intracanalicular tumor less than 1 centimeter in size. Facial nerve decompression and repair. Vestibular neurectomy. Advantages: it may preserve hearing. excellent facial nerve preservation, there is limited dural incision. Disadvantages. Neurologist less familiar with surgical anatomy of the area. Not recommended in old patients as the dura is more adherent and fragile. Temporal lobe retraction is seen. Cochlea, semicircular canals, and temporal lobe limit the exposure. Suboccipital retrosigmoid approach. Indications. Large cerebellopontine angle tumor more than 3 cm in size. Meningioma. Advantages. It preserves hearing. Large tumor can be removed in this approach. Facial nerve preservation possible. Disadvantages. Large exposure of the brain. Fundus is not visualized. Cerebellar retraction is seen. Postoperative headaches. Air embolisms are possible. Cerebrospinal fluid leak may also be present. Neurologists are less familiar with the surgical anatomy of the area. Cerebellum, brainstem, and posterior semicircular canal limit the exposure. Perioperative care. Cranial nerve and somatosensory monitoring. Electromyography technique for facial nerve and brainstem evoked response audiometry, or electrocochleography for cochlear nerve during the skull-based surgery are essential. Postoperative sequelae, complications. Common complications are sensorineural hearing loss, temporary facial nerve palsy and balance problem, cerebrospinal fluid leak, meningitis. Rare complications are stroke, intracranial bleeding, pneumocephalus, cerebellar ataxia, and even death. Image-based discussion. Here's an image of low and high power magnification of acoustic neuroma with zones of alternately dense and sparse cellularity. This 30-year-old female presented with hearing loss on the right and has findings consistent with an acoustic neuroma on the following magnetic resonance imaging. The T1 weighted image without contrast shows a mass centered in the right internal auditory canal. It is isointense to the brain parenchyma. Following gadolinium, the schwannoma enhances homogeneously and has a classic ice cream cone shape. The high-resolution T2 weighted image shows loss of the normal fluid signal in the internal auditory canal, which can be appreciated on the left side. The mass projects into the cerebellopontine angle cistern. Here is a right-sided image of acoustic neuroma of the 8th cranial nerve, is evident in the cerebellopontine angle. That's all for the video. We'll see you next time.